everybody. Recording live from somewhere. This is Zach Couples with episode number 109 of the Movement Debrief. And today, folks, since it is in the AM, there's only one thing I can say. Good morning, Viet fam. We're going to talk about one thing and one thing only. The scapula. We're going to talk about the mechanics during respiration, what happens when you join the compensation nation, and all other types of cool things like testing, treatment, all types of good stuff. Because I've had several questions that have been asked by the people. They'll be answered for the people by this people right here. Fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from Mike. Here's what Mike has to say. Simpler questions. He's got a couple of them. When talking about respiratory scapular respiratory mechanics, during inhalation and expansion, inhaled scaps are the following. Abduction, so apart from midline, external rotation, downward rotation, and posterior tip. Now the question is do these four movements ride together always with regards to a trainer's eye? To say a different way, if I protract and reach and inhale, like in a push-up position, should I have abduction, external rotation, downward rotation, posterior tipping, all riding together? Mike, this is an awesome question. So let's go over the normal respiratory mechanics real quick. And if you want to get a little bit more in depth, which I encourage you to do so, sign up for my newsletter because I go into detail with all the normal respiratory mechanics. That's the Human Matrix Foundations course. There will be a link to that in the show notes, which will be zachcouples.com/scapula at some point. Now, normal respiratory mechanics, real quick. I have two scapulas right here. We'll say the midline is, between them. That would be your spine. You're looking at a front view or you're listening to a front view. When I breathe in, the scapulae are going to abduct. Well, actually, let me preface this. With a normal breath, the model that we're assuming from is bilateral and you are getting multidirectional expansion in the thorax. That would be posterior thorax expansion, which we'll discuss a little bit later. So air is going posteriorly. You're getting the pump handle mechanism, which would be the rib cage moving anteriorly and superiorly. And you're also getting the bucket handle mechanism, which would be lateral and superior movement. The summation of those three movements would lead to the rib cage expanding in all directions simultaneously. And also the muscles that attach to the rib cage, the combination of those factors leads to the scapula going in this direction. When you breathe in, they're going to abduct, externally rotate, so the glenoid is going to point more outward, away from the body. They're going to posteriorly tip, because of the pump handle mechanism. They'll downwardly rotate. And then during exhalation, it's going to be the reverse of that. It's going to be adduction, internal rotation, upward rotation, and anterior tip. Especially useful considering what the normal resting position of the scapula is. At rest, whatever that means, the scapula sits at about 41 degrees of internal rotation under normal conditions, about 5 degrees of upward rotation, I believe 10 to 15 degrees of anterior tip. And when you breathe in, it moves away from that normal resting position, and when you breathe out, it comes back to it. With that being said, now the question is if I'm moving my arms and my legs, do I have these mechanics paired together? And the answer is no. Because when you're moving, you don't have that, two things. When you're moving, you don't have that uniform expansion in all directions. If I reach my arm into certain positions, I'm going to bias air into one area of the rib cage more so than another. So that's going to affect things. Also, you have to consider relative motions of the humerus in relation to the scapula. For example, let's look at upward and downward rotation because that's really the big thing that changes. When I breathe in, just a normal breath of air in, and we'll say I have full respiratory movement options and all movement options in my body, which is a pipe dream for me, but hey, let's just play along for a little bit. So I breathe in, I have that paired abduction, external rotation, and downward rotation. Now, if I've taken up all the slack at the rib cage and I start to raise my arm overhead, based on what we know regarding scapulohumeral rhythm, as I reach, I should actually get more upward rotation occurring. Well, how can that be that I can upwardly rotate the scapula upon inhalation? That's because as I reach my arm overhead, there's going to be a reduction of airflow posteriorly in certain aspects, depending on what angle I reach. So for example, we'll talk about this a little bit more later, when I reach forward at about 90 degrees of flexion, the scapula is more externally rotated, but it's also more upwardly rotated, which is going to create more posterior compression in the thorax. And that's because your external rotators and upward rotators are on the back side, a lot of them. So if I have that compression there, I'm going to be reducing airflow into the posterior thorax. That's also going to push more air forward into the anterior part of the thorax. So you can see, once I throw movement into the mix, things get a little funky. And that's really a big confusion point when we're talking about just basic breathing mechanics and not throwing movement into the mix. Anytime you take up slack at any one area, whether it's the thorax or the rib cage or the scapula, and then you throw something else on top of that, that changes where relative airflow is going to be and length-tension relationships of muscles. So to answer your question, Mike, no, these things are not necessarily paired together. We have a basic framework to operate from, which is normal respiratory mechanics. That's kind of a mid-range thing to consider in the sense that I'm not necessarily biasing air into one part of the thorax versus another. And when you have that happening, that's when you have the paired abduction, external rotation, downward rotation, and posterior tip during inhalation. That's going to change as soon as I start to introduce movement with the arm. Because when I move my arm, that's going to predispose air going into one part of the thorax more so than the other, as opposed to the uniform inhalation that we would expect with normal respiratory mechanics. And if you want a really good debrief that really deep dives into reaching and where air goes, probably more so than what we'll do today, I would definitely, I'll link it in the show notes. So to summarize, your great question, Mike, normal respiratory mechanics assume that you're getting the uniform airfill in all directions, but once movement happens, in order to move, in order to rotate, you're going to, by default, have to reduce air into certain parts of the thorax, so you create contractile actions, and you're going to have to increase expansion into other parts of the thorax to elicit eccentric things to occur. And the combination of those two alternations of contractions, concentric versus eccentric, is what allows you to move effectively. And that, by default, changes airflow, and that, by default, changes, to a degree, the paired mechanics that you're seeing when we're talking normal respiratory mechanics. Awesome question, Mike. A follow-up question to that would be from Mitch. Could you explain how upward rotation is part of exhalation mechanics? I'm trying to visualize it, but I'm having trouble connecting all the dots. We have to look first at what muscles are involved when we're talking about upward rotation of the scapula. And then we'll look at their locations. Your big upward rotators would be your lower trapezius, which runs from T6 to T12. It touches somewhere on the spine of the scapula. That would help with upward rotation of the scapula. That's one. The other big dog that we have to consider would be your serratus anterior, which is on the side of the rib cage, upper 8 or 9 ribs, in terms of their attachment points, and attaches to the medial border of the scapula. There's some contributions with the middle trapezius as well. It has a little bit of a disadvantage when we're talking about upward rotation, just because it's like more of a horizontal action, but it does contribute to some degree. So we'll say those three muscles are upward rotators of the scap. Why are they associated with exhalation? I want you to consider, Mitch, what the relative location of the anatomy is and what the goal is of exhalation. When I breathe in, I'm trying to take in air to fill the lungs into all directions so I can oxygenate my tissues. Then when I exhale, I'm trying to squeeze all of that air out so I can take new air in on the subsequent inhalation. Muscles that I referred to, which are upward rotators, due to their attachment on the spine and the rib cage, would assist in that squeezing mechanism. If you contract your lower trapezius, you're going to get more relative extension of the thorax, which is necessary if I'm going to push air out of the posterior thorax. When you breathe in, the kyphosis, or the amount of flexion that occurs in the thorax, ought to increase, at least in certain parts of it. On the side of the rib cage, where the serratus anterior lies, I should have increased lateral expansion, which is your bucket handle action. If you contract the serratus anterior, though, that's going to restrict that. It's going to compress the side of the rib cage in. So I have these muscles which help with upward rotation of the scapula. Essentially, when they contract, they're helping squeeze the thorax or compress it in all directions. And because that happens in order to evacuate air out, and their action is also upward rotation of the scapula, that's where you get the upward rotation action. It is a secondary thing to squeezing air out of the thorax. So to summarize your great question, Mitch, they're associated with exhalation, upward rotation is, because the muscles that upwardly rotate help compress the thorax, predominantly posteriorly and on the side, to help you get air out. Getting air out, exhalation, upward rotation. Another thing to consider is the resting position of the scap is in slight upward rotation. And so muscles that would help me inhale, which are downward rotators, that would be rhomboids, levator scap, pec minor, for example. All of those are more expansive when we're talking about their attachment point on the rib cage. The pec minor is going to help with the pump handle action. The rhomboid is going to increase the amount of flexion in the upper thorax. And the levator, of course, will elevate the scapula to allow for more inhalation to occur. So also consider that as well, that the downward rotators help with more expansion of the thorax. And it's those reasons, the compressive action of the upward rotators on the thorax, that lead to you getting upward rotation when we're talking about exhalation mechanics. Awesome question, Mitch. Paul asked a question on Instagram. Is passive exhalation a thing? Yes, Paul. It most certainly is a thing. A lot of the normal quiet exhalation that we would do when you're just breathing regularly is passive recoil of the diaphragm and the lungs evacuating air. When I'm talking about these exhaling and you're feeling abs and all that stuff, that's more of a forceful exhalation, which is used to drive movement changes. If I have certain movement limitations at rest, i.e. I don't have all of my movement options available when I'm being passively moved, you might need to use an extreme strategy to create those changes, because you're essentially trying to create or trying to change the contractile baseline of tissues. So that would require extreme actions. Just like if you were trying to put on muscle, you would need to create massive contractions to stimulate the tissues to do something different. That's very different from just normal quiet breathing that you're unconscious of. That is more of a passive thing that's occurring. So Paul, great question. The next question comes from Mars. Actually, these next two questions come from Mars. Hey, Zach, could you possibly talk about normal compensatory scapular movement for a narrow and wide infrasternal angle? If you don't know what the ISA is, I'll link it in the show notes. For example, narrow ISA tends to have anterior compression first. How would this impact scapular movement? I can't quite seem to understand this. Thank you. What happens at the infrasternal angle is your primary compensation when you can't reverse the respiratory mechanics that occur in the axial skeleton. So when you take a breath of air in, your spine generally moves posteriorly, and the entire spine. And that's necessary to allow for the lungs to fill posteriorly, as well as the viscera to move posteriorly and downward. Because when you breathe in, as the diaphragm descends, the viscera have to expand circumferentially into the ab wall, and they also have to move downward into the pelvis and the pelvis has to make room to catch the viscera. A way that it will make room is by counternutating the sacrum, which is part of the spine, hence being pushed posteriorly. When you exhale, the spine as a unit should move more anteriorly, which acts to squeeze the viscera so it moves upward, which allows more squeezing of the lungs to allow air to exit your body. So everything should move anteriorly or posteriorly. Now, let's say, based on a multitude of reasons, especially genetics, you have an individual that is better at one versus the other, i.e. they have more of an inhalation spinal strategy or they have more of an exhalation spinal strategy. You still have to breathe. You still have to be able to go the other way. A way that you can compensate for a lack of movement in the spine is at the lower rib cage. The reason being is because the lower rib cage doesn't have that common sternal attachment, so it has a bit more flexibility in that region. And that's where the compensations can occur. So someone who's good at inhaling in the spine can achieve an exhale through the lower rib cage. What that would mean is I would compress the lower part of the rib cage to make it look more like an exhalation-based strategy. That would be your narrow infrasternal angle, because under normal circumstances, when you exhale, the lower rib cage should get smaller. The same thing happens with a narrow infrasternal angle. The only difference is it's compensatory in nature, meaning that the way that it occurs is if the diaphragm descends towards flat, the line of pull that the diaphragm has changes on the lower rib cage. It helps invert the mechanics down there and allows for greater compression in that area. What doesn't happen is the diaphragm just descends, because then you would get air out, and that's the issue. I can't get the air out. So the diaphragm can't go up. It has to go down in order to attempt to get the air out in some way, shape, or form. So that's one piece. And actually, I understand it's probably hard to visualize when we're talking about this, or if you're listening to this. Again, if you sign up for my newsletter and you get the free talk, Respiration Revisited, it has better pictures of that as well. I would definitely check that out. The narrow infrasternal angle happens because if I'm breathing in and I can't exhale for whatever reason, I can compensate at the lower rib cage to make that happen. On the flip side, with a wide infrasternal angle, they're really good at exhaling, but they might not be able to push the spine backward for whatever reason. They might not be able to get the air in on the posterior aspects of the body. So their compensatory strategy is to inhale or widen the lower part of the thorax. So the infrasternal angle happens as a compensatory measure to allow you to complete the other side of the respiratory cycle. Sadly, when I use these compensatory strategies, I have a loss of movement options that occur as a consequence, because I can't move the spine in all the places that it needs to go. Now, when we're discussing what happens at the scapula, well, guess what, folks? A lot of your muscles that attach to the scapula have attachments on the spine. So if I have someone who cannot move their spine in all directions, that's going to impact the length-tension relationship of tissues that attach to the scapula. Let's think back to some of the stuff that I discussed before. If I am more inhalation biased, meaning the spine is more posteriorly, well, I should be able to get a good amount of air posterior, because those muscles would be more eccentric in nature. If I have increased volume of air going posteriorly, I by default am going to have less volume of air going anteriorly. It's like I have all this stuff tipped backwards. So because I have an increased volume of air posteriorly and a reduced volume of air anteriorly, I'm going to have more concentric activity with stuff on the front side of the body, and on the back side of the body, I'm going to have more eccentric activity. The tissues on the front side of the body, you don't have to know what they are, but due to their attachments at the humerus and the scapula, they're going to be more predisposed to pulling things forward. So the scapula are going to be more abducted and internally rotated, and probably anteriorly tipped to some degree. That's the position of the scapula when we're talking about someone with a narrow infrasternal angle. And it has to do with where that person can versus cannot get air. So they're just going to follow into that direction. Now, if the humerus also follows suit, since the pec is more of an internal rotator, you can't really use your arms effectively when your arms are internally rotated in this state. If I've taken up slack in the thorax and I've taken up slack in the scapula and I can't move the other way there, my only option is to move at the humerus. And oftentimes you'll see the humerus compensatorily externally rotate. These individuals will have limitations in more internal rotation-based measures. And that's the narrow infrasternal angle and their positioning. So I'll break that down one more time. Narrow infrasternal angle, more inhaled spine, so they're going to be better at pushing air posteriorly. They're going to not be as good pushing air anteriorly. Concentric on the front, eccentric on the back. That's going to pull the scaps forward into abduction, internal rotation, anterior tip, and probably a slight amount of upward rotation. If the humerus is also internally rotated, I have to be able to use my arms, externally rotate those things, because that's the only place I can create the movement, thus leading to limitations in internal rotation-based measures. Narrow infrasternal angle, scapula are generally going to be more forward. I say generally because there are secondary compensations that can happen that change that. For the wide infrasternal angle, things are simply flip-flopped. For those people, because they're exhaled, they're more concentric in the back, they can't get as much air back there. They have a better predisposition to getting more air in the front, because if I'm squished in the back, the air's got to go somewhere, so it's going to be pushed more anteriorly. Consider muscles on the back side of the body that attach to the scapula. So you have your traps, you got rhomboids, you got lots of different things in that regard. With that in mind, if those muscles contract, they're going to adduct and externally rotate and posteriorly tip and downwardly rotate the scapula. So the scaps are going to more likely come together, like so. Because the muscles that attach on the posterior aspect of the body, if they're more concentric and do their attachments of the scapula, they're going to pull things together. And that's going to limit more external rotation-based measures. Here's why. If I'm exhaled at the posterior thorax and the scaps are coming together, the humeri are going to be more externally rotated. Again, can't use my arms as well when I have this degree of external rotation. So you have a compensation into internal rotation to right your arms back to midline or back to center. So you can create more movement there. Also, your subscapularis is an external rotator of the scapula. Thus, if it's got increased tension there, it makes sense that the humerus would fall into more internal rotation. So because I'm concentric in the internal rotation, I should have limitations in my external rotation measures. Think of it as your internal rotators are shortened, thus you won't be able to stretch them effectively. Let me go through that one last time. Wide infrasternal angle, exhaled spinal strategy. The scaps are going to come together into adduction, external rotation, downward rotation, and a posterior tip. The humeri are going to have to internally rotate so you can right your arms back to center. Due to those factors, you're going to be finding more external rotation-based measures limited for those people. And that's the difference between the narrow versus the wide. Narrow, scaps are going to be more forward. Limitations in IR-based measures or internal rotation. Wide, more exhaled strategy. Scaps are going to be pulled back. They're going to be limited in more external rotation-based measures. Now, one thing you'll notice is the paired mechanics of the scapula were different from the normal mechanics that I discussed, if you were listening intently. The reason why that is because the mechanics I discussed earlier in the debrief are normal mechanics without movement restrictions. These are compensatory mechanics, so you can help move air in a compensatory fashion. That's the big difference, and often a confusion point for a lot of people who are listening to this stuff. So, awesome question, Mars. I had a few questions on IG. I want to make sure that I answer these. TWLV.Gauge. Would you consider someone with a swayback good at inhaling or exhaling? Awesome question. So someone with a swayback might not necessarily be good at either. And that's one thing I want you to be clear of with this. When I say someone has an inhalation bias or an exhalation bias, inhalation, spine going back, exhalation, spine going forward, that doesn't mean that they are rock star at that direction. It's just if you have this imaginary midline where I'm good at both, someone could be a little bit more predisposed towards inhalation, or someone could be a little bit more predisposed towards exhalation. But that doesn't mean that all of their measures are going to be clean. And in fact, from a practical standpoint, rarely are they. Someone with a swayback, rounded shoulders, they might be more biased towards the inhalation side of things, but that doesn't mean that they're good at it. Especially if there's other compensations at play, they could actually have some restrictions that would be more towards the inhalation side of things. I hope that answers your question. TWLV gauge. The question that this guy asked is, how do I get proximal hamstrings to influence the pelvis into posterior tilt? Proximal hamstrings are important. I don't think they're the show. But in order to get proximal hamstrings, you have to encourage a posterior pelvic tilt. And it's a little bit easier to do that if you have the hips into some degree of flexion, because the more I flex the hips, the more that posterior tilt or counternutation is going to occur. So that would be one way. Choose activities where the hips are more flexed, and some of my favorites would be like a rock back exercise, which I'll link in the show notes. I really like the drunken turtle. That's an awesome exercise because you get passive posterior tilting. 90-90 based activities are not bad, but you might even be better bringing the knees up a little bit higher to achieve that posterior tilt. Just because in that 90 degree of hip flexion range, you're going to have a little bit more of an exhalation bias because you're getting pushed more towards hip extension. The closer I get pushed towards hip extension, the more nutation actually you're going to get at the sacrum. Not necessarily an anterior tilt, but nutation at the sacrum. So there is a risk, though, of falling into a compensatory strategy there. But rock back, drunken turtle, anything less than 90 degrees is good of hip flexion. Squatting, also a money way to get proximal hamstring, high depth in particular. So that would be a way to do it. That being said, if your goal is to restore hip extension, proximal hamstring is not the show. The hamstrings are predominantly hip extensors in earlier phases of hip flexion. But once you get to the end range of hip extension, you should have more distal glute max, i.e. the femoral attachment of that. And that should be the thing that you feel, especially when we're talking about some of these ranges of motion. So that would be ways that I would consider driving the hip extension stuff you're talking about. TJ, awesome question. The last question comes from Mars. What is your go-to test to differentiate whether a client needs inferior or superior posterior rib cage expansion? They probably lack humeral external rotation in both situations, if I understand correctly. Thank you. Awesome question, Mars. There is a difference between superior and posterior expansion, and I will actually use the sacrum and lumbar spine as an analogy for that. So when you breathe in, the sacrum should counternutate, i.e. it should tip back. But the lumbar spine should flex, i.e. it should tip forward. So you essentially create this curve within the spinal complex that allows you to catch air in both directions. So I have a sacrum that tips back and a lumbar spine that tips forward. The same thing happens in the thorax. In the upper thorax, due to the first rib essentially being fused, it's a synarthroidal joint, so there's not much fluid there, there's no fluid there to move. The upper thorax would tip backwards into more flexion. And then the lower part of the thorax, we'll say like T6 to T12, should actually be in more extension, so you create that same ball. Since the mechanics are different, you can actually look at different tests to let you know whether or not you need to bias air into one aspect of the upper thorax versus the other. The way you would differentiate these two things would be using the scapula as your guide. External rotation. Those base tests would be the things that are limited, but depending on the level that you measure, that's going to influence where you should get air versus not. The big muscle that's going to be the limiter of anything that's external rotation based is going to be your subscapularis. Now I'll see if I can get a good picture of the subscap in the show notes, which I would look at for sure. But if you look at the subscap, the fiber direction differs depending on the location that you're talking about on the scapula. The upper part of the scapula, so near the spine and closest to the glenoid, or the spine of the scapula, I should say, is going to be more horizontal in nature, more transverse plane oriented. And then as I go towards the inferior angle on the scapula, it's going to be more oblique or diagonal in nature. So, tests that are more transverse in nature, more straight rotation, will talk to you more about the upper part of the subscapularis. And then diagonal-based tests in nature are going to talk to you more about the bottom part of the subscapularis. Now, why is this important? It's important because the spine position is different when we're talking about the top of the scapula versus the bottom. The scapula, in most individuals, runs from T2 to T8. If I'm talking more about the horizontal fibers, I'm going to be talking more about that upper part of the thorax, which, as we alluded to earlier, the mechanics, when I breathe in, should be more posterior and superior movement, generally. More flexion. As I get lower, 6, 7, 8, now I'm talking more about inferior or diagonal or oblique fibers of the subscapularis. I'm talking about the lower part of the thorax. That's going to have more of that tipping back, more extension-based things. So then the question is how would I know which tests would look at what? Well, also consider other muscles that attach to the scapula here. Scapula to spine, that is. If we're talking about upper thorax T2, T4, which is more oblique fibers of the scap, you have rhomboids. Rhomboids are a downward rotator. So anything that looks at more downward rotation would lead to appreciating more of the upper thorax here. Anything that's looking at more upward rotation, which would be your mid to lower trap, would have more of a mid to lower bias in that regard. So let's break that down into different tests you could look at. I can appreciate the upper part of the thorax with two different measures. I can look at external rotation at the side because the scapula is going to be more downwardly rotated. That would be one thing. If I'm limited there, then I know I need to get more upper thorax expansion. I could look at horizontal abduction as a test because that aligns the fibers of the subscapularis with the position that you're moving the humerus in. So there's two tests right there that would let you know if someone needs upper thorax expansion in particular, i.e. T2 to T4. If we're talking more about the oblique stuff, I could look at shoulder external rotation because that's a diagonal position. There's a little bit more upward rotation involved there. And although shoulder flexion could be another measure, although you would ideally need both upper and lower expansion to look at. And that's really your terminal test when you're talking about external rotation-based things. Your really big test to differentiate these areas for upper thorax expansion, you're going to look at external rotation at the side. You're going to look at horizontal abduction. For lower thorax expansion, you're going to look more at external rotation. And to get the combo, depending on where you're limited at in shoulder flexion, that would be the terminal measure. So if you got someone who can't get that last little bit of shoulder flexion, you're probably thinking of upper thorax T2 to T4 being limited. But if they're limited way early on in the game, then you're probably looking more at the mid to lower fibers just because the upward rotation hasn't happened. And those are really how to differentiate the testing in terms of where you need to put air. You just have to look at the anatomy, look at what the upward and downward rotators are doing, and then choose your tests accordingly. And if you do those things, You ought to be in business. Now, if you're wondering, well, okay, how do I do that testing and be accurate? 1. 2, how do I choose activities to help improve those movements? Because, well, okay, someone does have some limitations. How do I address that? And 3, how do I prioritize which ones to go after first? Your answers are going to be more in-depth and hands-on coached by your boy at Human Matrix. And I would encourage you, especially like if some of this stuff wasn't clear, and obviously, I'll probably go over it again at some debrief, but if you really want that hands-on instruction and application, because that's really where this stuff is going to stick, you definitely want to come to my seminal seminar. I added another one to the list, folks, and there's only a couple spots remaining, so definitely sign up. March 28th and 29th. I know it's a little short notice, but Madison, New Jersey. There are literally only 2 spots available, so you probably want to sign up if you can. April 4th and 5th. Atlanta, Georgia. The early bird is coming up fairly soon, folks, so I would definitely sign up for that. It's at the beginning of March, so you definitely want to sign up for Atlanta ASAP. May 23rd and 24th, Dickinson College, Carlisle, Pennsylvania. 14 Category A CEUs for athletic trainers, so you ATCs, you need some CEUs, you want a good seminar, come to Dickinson College. June 6th and 7th in Minneapolis, Minnesota. Definitely want to check that out. August 1st and 2nd, Boston, Massachusetts. September 12th and 13th, Montreal, Canada. 6 CEUs approved for athletic therapists, if you're an athletic therapist. October 3rd and 4th in Ann Arbor, Michigan. November 7th and 8th, Charlotte, North Carolina. And last one, November 21st, 22nd, San Diego, California. Please come to them. I'm continuing to make some adjustments, refine and retune. I think it's getting in a really good spot. I would love to have you there, especially if you need to do some practical application and practice this stuff and be coached as you're practicing this stuff. I think that's a good stopping point for us today. I want to thank all of you beautiful, sexy, outstanding people for tuning in. If you want to learn more about what I can teach you and what I have to offer, here's where you got to go. Go to zachcouples.com. As I had mentioned before, subscribe to my newsletter so you can get those talks that we talked about. You'll get access to the Human Matrix Foundation course. You'll get a free acute to chronic workload calculator. You'll also get goodies from your boy every Friday, all the cool stuff that I'm learning and what's going on the internets. I also offer 3 services on my page. Movement Consultations. If you're not moving as well as you'd like to, or maybe you have a client who's presenting with those tests and you're just unsure where to prioritize your interventions, or heck, you got a troubled client, you've done this stuff and you can't get those measures to change and you want some side-by-side coaching, that's where the Movement Consultation comes into play. What that looks like is I perform an evaluation, I look at some different testing to see what your movement capabilities are. I coach you through how to get those movements mo better, and we retest. And by golly bows, if we don't get some changes within the session, I won't be wasting your time. I won't be penalizing you for my inability to do that. So definitely sign up for a movement consultation, because more often than not, I definitely do get results, and if I don't, I know where to push you and know where to take you so you can get the results that you or your clients are seeking. Or if you want to learn how to do that with your clients, well, using a movement consultation is one way, but you need to get into more of the nitty-gritty side of things in terms of application and understanding. That's where the mentorship program comes in. We will go through some of the didactic stuff that I discussed in this debrief and more. And not only that, but what's most valuable is the homework side of things. I will have you go through case studies, send me stuff, let me know what you think, show me how you coach. I'll give you some immediate feedback with some cool videos and drawing and all that stuff so you can have your learning enhanced, because the best way to learn is to apply. And it's one thing to consume this stuff, but if you're not using it, you're probably not going to retain it as effectively. I would argue if you're not getting feedback on how you're using it, you're probably not going to apply it as effectively as you could. Sign up for the mentorship so you can get that feedback. Or if you want to apply this stuff to a fitness angle, you're post-rehab and you want to get back to lifting, or you're a coach or you're a clinician and you're wondering, well, how does Zach apply this stuff when we're talking about fitness? That's where the online training comes in, where I will take the movement consultation information, apply it to a training of your choice while keeping your goals in mind. For example, I have 2 clients right now who are trying to lift some heavy things. They're trying to show up at Ben House's Bro Retreat. If I would definitely go if you're interested, because Ben does some really cool stuff. I'll link him in the show notes. And they want to stay healthy during. So I've been able to design programs to help them prep for the stuff that they're going to have to do, bench, squat, dead, lift heavy things, while also respecting what their movement restrictions are. And my hope is that we get some improvements in movement and strength simultaneously. If this sounds like you definitely want to check me out for that. Once you've scoured ZachCouples.com, you'll want to sign up for me on iTunes and Stitcher at the Zach Couples Show. Because guess what, folks? There are 108 other debriefs out there, and, I didn't have 2 camera angles. I wasn't looking super cool like I am right now. You might want to just give me a listen for those. Please leave a review while you're there so the fam can keep growing. Other places you can find me, Facebook/ZCouples. Twitter is ZCouples, of course, and the Instagram, baby, at ZachZACCouples, CUPPLES. And I would also check me out on YouTube, because I'm putting out a gang of exercises every week almost in terms of things that I'm using with my clients. I would definitely try those out, especially considering some of the stuff that we talked about today. Perhaps you can go through my YouTube channel, search Zach Couples, and you might be able to say, oh, okay, I see based on the position that he's putting the arms, he's driving more upward rotation of the scapula. And that might influence horizontal abduction. That might influence external rotation at your side. Look at it with a critical eye, and most importantly, apply with your clients. Thank you all for tuning in. You've been a beautiful, sexy, outstanding audience. I want you to keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.